Good afternoon. Once again, welcome to Texila American University's session on COVID-19 and other high-threat pathogens in 2020. Welcome speaker, Dr. Patrick Chanda Kabwe, who is specialist in epidemiology. So let me give a brief introduction about the speaker. Dr. Kabwe is a medical doctor with postgraduate qualifications in field epidemiology. He is a graduate of the first cohort of the Advanced Field Epidemiology Training Program in Zambia. He has over 10 years experience in primary healthcare, saving the rural communities of Laupula province, Zambia. He has served as a district health director and public health specialist under the Zambian Ministry of Health. He has experienced in outbreak investigations and clinical management of diseases of public health importance. He joined the Africa CDC at the African Union headquarters as the COVID-19 event-based epi-analyst deployed by the African Field Epidemiology Network through its disease detective network. So on behalf of Texila American University, I welcome the speaker, Dr. Kabwe.
Thank you. Good afternoon, everyone. It's indeed my pleasure to talk to the Texila management and, of course, students and all other public health people that are on this call. So we'll talk briefly about what's transpiring right now, and I think we know it's the COVID-19. We'll talk about that, and of course, as we start discussing, also be looking at the role in which each and every one of us can play a role in terms of how we can control the spread of COVID-19 in our setting. So how, as health professionals, how can we come in and help and be part of the fight against this disease? So I did prepare some talking points, presentations that we'll go through, and of course later on we'll look at areas in which we can discuss in the Q&A. So the objectives of this webinar was, of course, we'll just try to describe what's happening in terms of the epidemiology of COVID-19, and also look at the public health and social measures of COVID-19 that are helping in terms of controlling the disease and what the role each and every one of us can play in this fight. Next slide. Thank you. All right, so let's look at briefly on the global health security. Right now, the world is having a lot of challenges in terms of diseases of public health importance. And of course, public challenges are getting increasingly complex and rapidly changing within the context of climate change and environmental degradation. There's rapid urbanization. A lot of people are moving to urban areas. Of course, rapid growth of our populations, that is also a factor. And because of all these interactions, especially with the urbanization, there's this huge interaction between humans and animals, and as we are seeing now, a lot of more infections will be coming in from animals into humans because of these interactions that are going on. We are seeing in a lot of places where the human population have actually gone into, for instance, forests where they are having habitation, industries, homes, and all that. So this linkage with the environment actually contributes to the emergence of all these public health issues that we are currently having. Next slide. Okay, so we'll just look at a brief background to the current epidemic. So on the 29th of December 2019, we heard of 4 cases of pneumonia of unknown origin reported in Wuhan. And China notified the World Health Organization on the 31st of December. Later on 7th of January, we had 3 patients in whom the novel coronavirus was isolated. And later on, the disease was named by the World Health Organization as COVID-19. And by March 11th, the World Health Organization declared COVID-19 a pandemic. So these are a sequence of events to what's obtaining right now. And next slide. So we'll look briefly about the epidemiology of this COVID-19 so that we will understand in each of these. So before we could look at that, look at the core competencies. What is expected of us as public health professionals? So the first thing is, of course, we need to be part of disease outbreak investigations. And of course, we need to be part of designing appropriate interventions that are evidence-based in terms of controlling outbreaks of any nature. As public health professionals, we need to ensure that we are in the forefront of implementing health surveillance systems. And of course, we need to evaluate it to see how functional it is, identify the gaps that could exist in our surveillance. Because remember, surveillance is key, it's part of disease intelligence, because without surveillance, then we're at a serious risk of these emerging, re-emerging and emerging diseases. So we need to be on top of things as public health surveillance. So how do we ensure that our surveillance are actually functioning actually very well? Okay, so another issue we need to look at, appropriate research. What research methods do we understand, okay? And how can we apply in terms of controlling these outbreaks, the health problems that we have? How can we solve them using appropriate research methods? So these are the competencies that is expected of us as public health professionals, even as we go through different trainings. Of course, we need also to know that, we need to lead and manage health systems, implement as well as monitor and evaluate public health programs in line with country's health policy. So this is actually quite key as health professionals. Of course, we need to apply the basic principles of social, environmental, and occupational health in solving public health problems in a given context. If you look at the interventions right now in terms of COVID-19, there are a lot of social aspect of this. So these are the issues that we really need to be focusing on as we go through our training as public health professionals. And also, we also need to know how to effectively communicate both orally and in writing, as well as to be able to critique scientific literature. This is actually quite key. And of course, we need to demonstrate professional and ethical conduct in our day-to-day duties in the profession. Next slide. So let's briefly look at what has brought us here in this discussion and our role we can play. So let's look at the epidemiology. So as we look at the epidemiology, we also pick on how we can actually help in terms of intervening, coming up with interventions on how this disease is transmitted. So we look at the dynamics from this information from both China and Italy. So what we see in patients for COVID-19, we are seeing that majority of cases arise from close contacts of symptomatic cases. And in a study that involved about 38,000 close contacts, close to about 5% of them did develop COVID-19. So this was seen that family clusters was actually a big driver of infections in about 78 to 85% of clusters. Then also look at, in terms of the secondary household attack rate, if someone is infected in a household, how many of those in the household get infected? So early on in the outbreak, before isolation, to discover that that was 10%, but because of the public health interventions that were put in place, this dropped to about 3%. Transmission in closed settings then was happening in China, but at that point, they had already closed most of these nursing homes, schools, so they were really not able to determine this. But of course, in our settings, we are seeing that transmission is actually happening in closed settings. Next slide. So let's look at the natural history in terms of epidemiology of COVID-19. So at diagnosis, slightly over 80% of cases are mild to moderate, and 15% are severe, 5% are critical. Then in terms of disease progression, we're seeing that this 80% who are mild, 10 to 50% of them will develop a severe disease, and this 15% who are severe, about 15-20% of them develop critical conditions requiring critical care in terms of ICU admissions. And in terms of the symptoms, the average time from exposure to symptoms is about 5 to 6 days. And from symptom onset to recovery, for mild cases, about 2 weeks. And for severe cases, about three to 6 weeks. So for symptom onset to death, from the time someone develops a symptom onset to the time when they die, usually takes close to about, okay, so it takes close to about 2 weeks. And of course, children tend to have a lower mild presentation. You can go to the next slide, please. So in terms of the virology, so shedding is highest in the course of the disease. Virus shedding can occur in the 24 to 48 hours prior to a symptom onset. It has been shown that virus could be isolated in stool, but however, there's no epidemiological evidence right now to suggest that there could be a fecal-oral transmission of the disease. So the virus that was isolated in stool, none was actually cultured in terms to see how viable and transmissible the virus was. Another thing as well is, the virus has been isolated in blood. It has also been isolated in semen. So evidence as well happens to be shown that there's transmission via these routes. So we are waiting for more information. Right now, there's no expert in COVID-19. So we are learning and learning on a daily basis. Then in terms of viral shedding, so the virus could continue to shed for close about 7 to 12 days in mild to moderate cases, and for greater than 2 weeks in severe cases. And patients, okay, there's something that keeps on popping on my screen. These people that are joining in, how can we deactivate this one? Okay. All right, so patients who recover can be PCR positive after a symptom resolution. So what's happening actually in this aspect is, the key diagnostic right now is through PCR. So you get your oropharyngeal or nasopharyngeal swab that is subjected to a PCR. So within this period, between 7 to 12 days, in the mild cases, we realize that this shedding would actually end. And later on, you find actually that's when you begin to isolate the virus in the stool. So again, as I said, there's really no evidence that the fecal oral transmission is actually happening. Next slide. So I looked up as a study which showed some of the transmission dynamics. This was a preprint. So basically, in this study, they sampled the areas of patients' isolation rooms. They sampled the toilets, the beds, toilet pans, door handles, the air vents. And what they found was that most of the items within a facility where a COVID-confirmed patient was isolated, there was serious environmental contamination. And this is one area where, we talk about daily cleaning of mostly frequently used as surfaces, because studies have shown that on most of these surfaces, the virus was there and it was viable, meaning it would be able to be transmitted from any person that was in contact with the virus. Next slide. So again, we are hearing a lot of asymptomatic infection, and one of the key challenges that has been with COVID-19 is that people would actually start transmitting it even without showing symptoms. So some of the studies that we did look at truly asymptomatic infection, is unknown without serology. Right now, serology is being developed, not really. Some of the serology antibody tests that have been released, some haven't really shown a good specificity and sensitivity in terms of either ruling out or rather confirming that this could be, this could be a COVID-19. So unless we have a serology, that's antibody testing, then we would know really what's the statistics in terms of the truly asymptomatic infection. But with the molecular testing, the piece which we're using, usually it's difficult to diagnose it early on during the pre-symptomatic or asymptomatic stages. And of course, one key thing is that this patient who are symptomatic, 75% of them do end up developing symptoms. And a study which screened 89 studies and of course included 11 of its own showed that 29% of COVID-19 patients were asymptomatic. Okay, and of course, this one, we couldn't rule out issue of selection bias and of course selective publication bias in this aspect. So there could have been some confounders in that aspect. Then one statistical modeling study did estimate that 18% of persons were asymptomatic, and another modeling study did indicate that 40 to 60% of the cases were as a result of transmission from a pre-symptomatic or asymptomatic individuals. Next slide. Okay, so we look at also another aspect that as public health officials, we need to know in terms of when do we apply our interventions, what roles are we going to play? So we'll look at the reproduction number and the herd immunity. I'm sure I'll go ahead of this. So a reproduction number is basically the number of secondary infection that a single primary case can produce. Okay, so to derive by this realistic reproduction number, previous estimate of the serial interval. So the serial interval is basically the development, the number of days it takes for development of symptoms from a secondary case, from a primary case. Okay, so initially it was estimated that 7 to about 8 days or serial interval was described in China. And this serial interval is actually dependent on the time to hospital isolation. And of course, the reproduction number can be lower if the serial interval is shorter. Okay, so basically meaning, you would have a few number of cases if the number it takes for symptom to develop in cases is also shorter. So however, recent studies report that persons can be infectious for a longer period, such as 1 to 3 weeks. And honestly, other studies right now are also showing that people can be infectious even for about 1 month. As I say, there's really no expert in that. And of course, right now, what we know is the reproduction number right now stands at 5.7 from the recent studies. Next slide. So let's look at the implication of the reproductive number for intervention strategies. So as I said, the reproductive number is estimated to have been important, have got important implication for predicting the effects of pharmaceutical and non-pharmaceutical intervention. So in terms of us public health professionals, we are concentrating more on the non-pharmaceutical interventions. So for example, the threshold for combined vaccine efficacy and herd immunity needed for disease extinction, that's to suppress the transmission of COVID-19. So that's a formula that we do use. So if we say the production number is 2.2, so we mean if the production number is 2.2, it means each patient can infect close about 2 to 3 people. So this threshold is, if it's at 2.2, it means 55% of the population will be infected, and that those that can be immune and protected after recovery. And if your reproductive number goes high, which means each single case is infecting many people, close to 5, then it means you're going to have close to about 82%. And to achieve immunity in terms of the population and to cut the spread of the disease, you need to have at least more than 82% of the population to be immune. And this immunity could be gotten either through vaccination, and right now, of course, we don't have any vaccine, effective vaccine against COVID-19, and it will take a lot of months for us to have this. So another thing is if you have a high reproductive number, meaning you are not doing your interventions, and your reproductive number is going to high. So you're going to have a lot of people getting infected. And if indeed the antibodies which are being produced after COVID-19 infection are protective, then it means your population is going to be protected. But again, as public health officials, we are applying these interventions because again, if you allow your population to be infected at that rate, it means those that are vulnerable to infections like people with comorbid conditions like TB, diabetes, hypertension, cancers, and all those things, they will actually die in number. So again, you don't want that. So the only key is to ensure that there is an effective medicine or vaccine that can actually slow the spread of this COVID-19. Next slide. So let's look at the public health and social measures and our roles as healthcare, as public health professionals. Okay. So why are we talking about these social and physical distancing measures? Why are they important? Okay. So specific transmission characteristics of COVID-19 suggests that community social distancing is necessary to delay and reduce the magnitude of the outbreaks. So we know that transmission occurs frequently among close contacts. We know that transmission may occur from people who are infected and do not yet have symptoms. And we know that transmission may occur from people who are infected and never develop symptoms. So this tells us that we need to apply measures that are going to stop this transmission among contacts, transmission from people that we don't even know have symptoms. Next slide. Okay, thank you. So we'll look at what's the rationale for physical distancing and social measures in the COVID-19 response. So basically here as shown from this graph, we have social distancing delays an epidemic and reduces the number of cases at an epidemic peak. This just doesn't apply for COVID-19, so it applies for all the public health threats that are out there, okay? It could be the H1N1, it could be the cholera, which is always with us, and any other measles, and all those things, polio. So all these, we need to ensure that, we delay this epidemic so that, we have enough time for health facilities to attend and manage the number of patients without reducing care. Remember, apart from COVID-19 patients, we also have other patients that need care. So public health officials also apply the knowledge. Okay, so right now we're looking at the evidence that's coming in, what's happening, how do we, stop transmission of, our current public health threats. So it gives us time to prepare for that. And of course, for researchers to have more time to develop treatment and vaccines. So what these public health measures do is they just prolong the outbreak so that you have as few number of cases so that the health system is able to handle the number of infections. Let's go forward. Next slide. So one key important that we need to play is issues of community engagement. Community engagement is quite key in terms of handling any disease outbreak. And one of the key aspects of community engagement is actually risk communication. So risk communication entails you find a way in which you're going to communicate with your audience, okay? So the communities, they need to ensure that you are trusted, the information that you're sharing are trusted. You need to tell the communities what you know about a disease that is happening in your setup, what you don't know about it, and what you are doing about it, and how the interventions that you're going to put are going to affect us, their social lives, their economic lives, and all the negative consequences of that. So, for instance, if you had an outbreak of maybe measles in maybe Chivoli or maybe in Kanyama, you need to ensure that you involve the leadership. Communities have got these structures. Involve them. Tell them what you know of what's happening. Engage them. Okay, make them to be part of the decisions. Ask them, what do you want us to do? How do you think this intervention is going to impact your community? That is key. That is key to ensure that the communities understand the aspect of interventions. You can have all these measures that you have, but if the community doesn't understand what you're doing, they don't trust you, then honestly, it's a battle you are losing. So you need to carefully engage your communities. So that's one of the important roles we need to play as public health professionals. Next slide. Okay, so these are just some of the community level social distancing measures we have. Of course, we know His Excellency, the President of Zambia, ensure that the educational institutes were closed. Special populations, were needed to be taken care of. Those, where were like nursing homes, patients with chronic conditions, vulnerable populations, so those needed to be protected. Of course, no mass gatherings, meaning in terms of cultural events, sporting events, festivals, and conferences. Okay, and in some aspect, like what's happening in Nakondi right now, where they've done a lockdown. So that's an issue that we need to talk about. What are those implications in terms of the lockdown that is happening, for instance, in Nakondi? What role can we play? Does the community really accept this? Because if the communities don't really accept this, you find that violence can erupt. People adhere to these things. But if you talk to communities nicely, they understand you, they trust you, then all those things can be are delayed and controlled. So basically, these are some of the measures that will be important. Right now, we are seeing some of the measures being lifted, what is now termed as the new normal. So basically, as we lift those measures, what are we advising our leaders, as public health officials? Okay, and one important aspect as these measures are being lifted is issues of the epidemiology. What is the public health information? What is it telling you? What is it telling us in terms of lifting the measures? Okay, what is the incidence, for instance, of infections in Lusaka alone? Okay, which places are most affected? Why should you, for instance, close this place, open this place? So you need to use scientific information to make such decisions on when to close and open up. And I think I would cover that. Next slide. Okay, so let's look at when do we adjust some of these measures. Of course, this should be based on the information that we have. So public health and social measures should be used in combination, of course, tackling at different times to ensure you reduce the risk and limit the impacts on the community. So basically, it's supposed to be a state-by-state process. You don't want to lift all these social measures together, or you effect these measures at the same time. So it's supposed to be a step-by-step process. Saying, when adjusting social measures, you need to look at the epidemiological information, scientific information, public health information. It's supposed to direct our leadership in terms of, when to apply these measures or to lift these measures. Okay, so you need to look at the incidence of confirmed or probable cases in that locality. We need to look at the positivity rate in that locality. You also need to look at issues of healthcare capacity in terms of you lift a measure and there's a resurgence of diseases. Have you put in place policies that will ensure that you confirm, isolate quickly, treat cases, find all the contacts and you quarantine them? So you need to look at what is our capacity as we are relaxing these measures. So it's supposed to be a step-by-step process. And in this step-by-step process, you need to ensure that you use the scientific information, epidemiological information. For instance, incubation period for COVID-19 is 14 days. So you can apply measures initially that will ensure that within that 14 days, if no more cases, okay, are being confirmed, then of course can begin to relax them, okay? And of course, you also need to have the capacity of ensuring that you can effect back these measures when you see actually more cases are being recorded. So basically what I mean is you need to ensure that you have data to inform any decision whether to effect a measure or to lift a measure. Next slide. Okay, so I think this should be my second last slide. So, so when can we reduce this public health social measures in terms of the COVID-19? So of course, when you see there's a decreasing number of new cases, that's laboratory testing has improved or is stable. When you see a decreasing number of cases from unknown chains of transmission, when you see a decline in deaths for at least 14 days, when you see a decreasing healthcare worker infections, as you are seeing, we've got quite a number of healthcare workers that are getting infected, and if more of the healthcare workers are getting infected, then we have a problem. Then, of course, sufficient number of trained staff and the personal protective equipment is available, or it has doubled. You've got hospital capacity, which could manage, if cases start doubling. Contacts are identified for all positive cases with at least 90% follow-up. So this is key in terms of contacts. So like what's happened in Nakonde, I'm told there are issues of sex workers that are actually, helping in contact tracing. So we are hopeful that, they help identifying their clients and, we stop the spread. So what we need is to ensure that 90% of follow-up of all contacts needed for it to achieve control of this epidemic. Of course, non-COVID healthcare services are able to deliver adequate standard care safely. If you go diabetic patient, hypertensive patient, asthmatic patients, malaria, HIV-related, illnesses, we need to ensure these non-COVID essential services would continue. That's where we can begin to reduce on some of the public measures that have been put in place. Next slide. So, of course, you can also increase these measures if you realize that you start having new cases. The doubling time of cases is more. Okay, if you are seeing more, chains of transmissions within a 14-day period, you see more and more healthcares are getting infected. You are seeing more admission to COVID treatment centers, lack of bed capacity. If you have the inability to test contacts, that's a problem. So you need to ensure that those public health social measures are put in place back. And of course, we've got shortages of PPE. And if you can't effectively implement essential healthcare services, then you might need to protect your community, and you need to ensure that these measures are increased. Next slide. Okay, so so this is just again, you can next slide. Yeah, so these are some of the non-pharmacological interventions. I think I did mention those, and I described them as we are talking. So you've got universal population measures, isolation of and management, contact quarantine, suspension of public gathering. So we've talked about this. Now, next slide. And I also talked about this. I think this should be my last slide. So thank you very much, and over to you. Thank you.
Thank you, Speaker. I believe the session was really interesting, and most of the participants were able to have an information about this particular pathogens and other upcoming activities, what can be done in order to get rid of this COVID-19 and protect the environment from the COVID-19. So let us get into the chat, because as we speak, we had received more chat from the participants. So I'm reading the chat messages one by one for you, Speaker. So it'll be easy for you to answer the questions one by one. So the first question is, obviously, first comment is always a compliment. There is a person who commented that nice presentation, though I didn't join the time due to network issues. So he had given the email address, and yeah. The next session is okay. Good. Yeah. Concerning sex workers, it's beneficial denouncing their clients in order to effectively identify possible cases. But is it unethical denouncing them? That's bridging of confidentiality, isn't it? This is one of the question, Dr. Patrick.
Okay, so in terms of sex workers, okay, that is a tricky one. Honestly, you know, I was actually joking when I was actually mentioning about sex health, sex workers out there. I'm sure in terms of confidentiality and all those things, I really doubt if really they'll be helpful. Though in some sections of the media, I'm told, you know, they've been helpful in terms of contact tracing, but that is really a challenge, because probably some of them wouldn't even know some of the people they did sleep with. So it's a challenge. And in terms of the spread of the infection, you know, with such kind of a cluster, it's really a challenge to have this case, and no one will come out to say, yes, the contact was actually, you know, the sex worker, or the sex worker say, no, that person. So I don't think that can be happen. So I'm sure, you know, the disease intelligence wing of the Ministry of Health, the Zambia National Public Health Institute, is on the ground to ensure that, you know, at least more than 80% of the contacts are going to be identified in Akonde, and of course, the needful will be done to ensure, you know, we control what's happening in our busiest border town. Thank you.
Fantastic, Doctor. The next question was, again, it's a compliment. It was a brilliant presentation. I believe that's the only question we have, and I'm not sure any other questions are raised apart from that. Dear participants, if you have any questions which you would like to ask the speaker, please feel free, and you can raise your hands in your session so that I would be able to identify it from our screen, and I can unmute your mic so that you can discuss with the speaker on your query. We have so we have a question from TechnoSpark. I don't know, I think they had used the name differently. Yeah, please go ahead. The first question we are asking from Mr. Kingsley Poncham.
Yeah, I don't know if you can get me, Doctor.
Yeah.
Yes, you're loud and clear, sir. You're loud and clear. Please go ahead.
All right. Thank you so much. I really want to appreciate the speaker for the wonderful work he had done. The presentation was wonderful. I really so much appreciate it. Yes, and I also want to find out something. You talked about what viral shedding is all about.
Yeah.
I kind of, it was not well understood because it was kind of a bit fast, and then the network too was not really that stable.
Okay.
So I didn't really get much on viral shedding. Then you also talked on the number of reproductive number and the health of immunity. So I didn't really get much on that too as well.
Okay.
So actually we just want to get more light on the viral shedding and the reproductive number as well as the health of immunity. Then I also have some observations.
Okay.
Some observations too to give us regarding the presentation.
All right, great. Okay, so in terms of viral shedding, so we are saying the viral shedding is highest early in the course of the disease. All right, so when someone gets infected, remember the incubation period is at least 2 days prior and up to about 14 days. That is like the incubation period. So early on in the infection, that's when there is a high, viral load, and it's a point where you can easily diagnose COVID-19. The other thing I mentioned on viral shedding is that viral shedding can occur in the 24 to 8 hours prior to symptom onset. Again, this is shows the level of asymptomatic cases that might be there and spreading the infection. Then the other thing I did mention was viral shedding can continue for close to about 7 to 12 days in mild and moderate cases, and for more than 14 days in severe cases. Then the other note from the evidence that is coming out is that the virus is also shedding in the stool. But in the stool, the other thing is that no one has actually right now isolated a virus which is viable, which means it can be able to transmit via the fecal-oral route. So the other thing is the virus has also been identified in semen. So again, studies are also are going on to ensure that we know if through those routes people can get infected. So that's briefly what I talked about in terms of the viral shedding. Then in terms of the reproduction number, so the reproduction number, I did describe that this is the time, rather this is the number of secondary cases that one case can produce. So without any interventions, this number could be as high as 6. With interventions, this can be reduced to about 2 or so. But what you want is to ensure you get a reproduction number of less than 1. Once you get a reproduction number of less than 1, it means your community is protected and the transmission would actually be stopped. So basically, those are 2 things that I talked about in terms of the reproduction number and the shedding of the virus. I hope it's clear. Thank you. Over.
Thank you, Dr. Patrick. And we have the next interest is from Mr. Suleiman. So, Mr.
Yes.
Suleiman, please go ahead. You can talk.
Yes, thank you very much for the presentation. Yes, so I wanted to ask a question concerning there is a drug, a herbal medication that we are hearing. Is it appropriate to have a clinician's try?
Suleiman, can you
herbal medication from Madagascar?
Yes, sir.
Yes.
All right. Thank you for that question. Yes, we have heard about the herbal medication in Madagascar, and that is actually some explain the reason why Madagascar got few cases and haven't recorded any deaths. But as scientists, of course, we need more information to see really what is the active component in that drug. And what we base as scientists, as public health officials, is the standard is we need to do the randomized clinical trials on patients to see really what is the outcome of that. And it's important note also that the government of Madagascar is right now, of course, engaging like the Africa CDC, engaging clinicians, researchers of the continent to study it in patients and really see its effect. So right now, we don't have any data in terms of its effect, its toxicities, and all that. So we really can't much comment on that one, but we hope to get more information as the research is being done on the Madagascar medication. Over. Thank you.
Thank you.
Thank you, Doctor. Thank you, Suleiman. Now, the next question is from Ivat Mugarura. So I'm unmuting your mic, so please you can go ahead.
Yes, thank you very much. Okay, please. I was thanking the presenter for well articulated presentation. I'm Reverend Ivat Mugarura from Uganda.
Thank you.
My question is on the emphasis on community engagement. Yes. And the question is this a role for public health specialists? If it is a yes, how because I'm looking at a public health specialist just divorced, almost detached from the community. And I wanted to find a clear way of how this public health specialist can engage effectively the community for the community engagement that has been emphasized.
Thank you very much, Reverend. Yes, definitely the public health specialists are actually key in the management of COVID-19 patients in this pandemic and in all other pandemics that do happen. So we shouldn't divorce the public health specialists that we have. So there are guidelines right now which can be found, I think, on the US CDC websites, on the World Health Organization about risk communication. So risk communication has got all the guidelines that are listed in terms of how can you go about in terms of reaching out to the communities. I'm sure even like the health departments within our countries, I'm sure they've got people that are actually doing this work, and we need to engage them. We need to see the action plans, their plans. What are maybe your district plans? What are your provincial plans? What are your city plans in terms of engaging your community? So these plans should be well elaborated. If there are no plans, then we need to put up plans. How do we engage the communities in terms of this fight against COVID-19? Because as I said, the communities need to understand what is happening, what you know about a prevailing public health threat, and what ways are you going to ensure that you intervene. So guidelines are there on these public health websites, and of course, local guidelines are there within facilities. So we need to look at the action plans. For this outbreak, I know most countries have got the incident action plans that have been developed, and in those incident action plans, they have a big aspect of community engagement. So we need to look at those things and go into these communities and see what role we can play. Thank you.
That's a very good question raised by the participant. Thank you, Doctor. Before we get into the next one, I have an interesting question which has been raised by a person, Elimia Tembo. How is that COVID patients are getting healed without the treatment available for COVID? I think this should be the question that most of us are looking around it.
All right, thank you so much. That's a very good question. So basically, the way viruses are, especially the respiratory viruses, okay? Just like we all have had a flu, a common cold, where we have fevers, headaches, body pains, chills, and all those things. We don't usually get any medication for that. Sometimes just say, get in a Panadol, get flu. Some have all these herbal, mixtures, or they'll have like garlic and all those things. So basically, all those is just to relieve the symptoms. So what happens if someone has got COVID-19? So you are admitted in health facility, and trust me, no single medication is going to be given to any of these patients. There's no medication or vaccine to be given. So what we do is we are going to help your body fight the virus. So by helping the body fight the virus, we are going, of course, to ensure that you are hydrated. We give you some we give you enough fluids. We need to ensure that we give you good nutrition. Okay, we need to ensure that we control the pain that you are having. And if you are very ill, of course, we can put you on oxygen to ensure that it helps in the breathing, because this affects the lungs. And if with all this support, the body itself, using its own immune system, immune cells, is going to ensure that actually there won't be any terrible or rather bad consequences from the virus. And the virus will eventually run its natural course and it will clear out from the system. So that's why we're saying we need to identify as many cases as possible so that we help you. Okay, so we're basically just going to observe you, give fluids, give painkillers, nutrition, and all that thing. And that will help you to ensure that within 7 to 8 days, patients begin to recover. Usually after 10 days with symptoms, usually sometimes they can actually progress into a severe illness. So if they're in severe illness, we'll just basically give you oxygen and help you breathe and let your body fight on its own. So just like any other flus that we have, COVID-19 is also a form of a flu. So it's a self-limiting infection and it will clear out from the system on its own. But it's important to know that it's only very aggressive and very fatal in people that have got other conditions like diabetes, hypertension, cancers, people that are HIV positive and they're not on their drugs. Those are the people that are highly affected by this. But the majority, as I say, more than 80% will just be a mild infection that will run its natural course and clear out from your system. So that is basically what we say supportive treatment. We just help your body fight the virus without any medication. And this is what we are doing worldwide. So each and every country in the world that's COVID-19, that's what they have done. Thank you. Over.
Fantastic, Doctor. We have a second interesting question again, which has been puzzling around an individual in the countries where the COVID-19s are extremely high. Are reusable masks safe?
Thank you for that question. So yeah, with COVID-19, there's an issue of the demand in terms of PPE worldwide, and as in resource limited settings, our situation is even worse. But the reuse of masks is not recommended at all. The reuse of masks is not recommended. Right now, the WHO, CDC, there are some studies, trials that are used. I mean, they're studying right now in terms of how can you reuse, for instance, an N95 mask, for instance. So there are other things that can be used to reprocess some of these masks, but of course you need the high tech to do that, but in our settings, I don't think that would be possible. So a reuse of mask is actually not recommended at all. For N95, there are times where sometimes we say you use it for an extended period, meaning when you remove it, you remove it carefully. You wash your hands before removing it. Don't touch the front of the mask and put it nicely in a paper bag and close it. Then, of course, you can use it later after a few days. So it's not as extended use. But right now, that can only be done if we're really faced in a situation where we have completely run out of masks. Otherwise, mask reuse is not recommended. And the other thing is in the health setup, never use a cloth mask. We should all use either a standard surgical mask and an N95 mask. Thank you. Over.
Fantastic, Doctor. Thank you so much for the beautiful answer. And we have Barbara Ngandu. Barbara Ngandu, you're unmuted. Please go ahead with your question.
Okay, thank you very much. Good afternoon.
Good afternoon.
Yes, Dr. Kawe, I heard you talk about PCR, talking about the patient who has recovered. Yeah. And remains PCR positive.
Yeah.
Does it mean this patient remains infectious?
Thank you. Great question. So, as I said, virus shedding depends. In mild to moderate cases, it can take close to about 7 to 8 days. In severe cases, it can take about 14 days or more than 2 weeks. For that to happen. And sometimes once the virus shedding stops through the respiratory path, you find that it's being shed in stool. But of course we have, as I said, right now there's no evidence that that virus is actually viable. So sometimes when you do PCR after a patient has recovered, sometimes it could just be remnants of the RNA of the virus. And when you detect that RNA, the PCR, because the PCR uses genes. Okay, there are some genes that these PCR machines that target. There are several genes that each of these the manufacturers actually put up. So they target certain genes on the code of the gene, the genome of the COVID-19. So sometimes that virus, even if it's being shed, it actually couldn't be a viable virus, for instance. So again, we can't say with certainty that when you detect if the PCR is positive in a patient that has fully recovered, then they are either not transmissible or transmissible. The only thing is we need to have evidence to show, is it just remnants of the viral RNA? Is the virus viable? So you need to culture that RNA, that confirmed PCR test, culture it. If you culture and be able to grow that virus, then it tells you that that is transmissible. But right now, some of the studies that have shown that some of those is just the remnants of the RNA that remains, that will show that a person is actually positive after recovering. In other patients, it's been shown that someone tested, because for you to be confirmed healed or cured from COVID-19, you need 2 PCR testing negative 24 hours apart. Okay, so when that happens, then you are cleared, you're able to interact with the community. But of course, some of later on tested positive after testing negative. So again, it's sometimes could be contamination as well, and sometimes that could be just in a fragment of the RNA, but it could not actually be a viable virus. Thank you. Over.
Thank you, Doctor. Thank you. Good. Thanks for the question, Ms. Barbara. We have 2 questions, Doctor. One is, how would people in rural areas could survive with COVID-19 as people are less aware of this pandemic? The second question, which is related to the mask, what about the use of washable masks, like masks made with fabrics or cloth? How safe and protective is it?
Thank you. So in terms of rural setup, that's again our role as public health officials. So if we've noticed that actually, in these areas, people don't have information about COVID-19. That is our role. Okay, if we're not working within these health agencies, then we need to find a way. Because remember, in terms of our career path as public health officials, it's either you work for the government, you work for the non-government organization, of course, or you run your own public health consultants. So those are our career paths. So depending on where you are, and you realize that you've got information that in this area people don't have the privilege of this information. We need to go in. Let's find ways so that we engage our communities. That's why it's important to check, risk communication. How do we engage even the most vulnerable population, the hard-to-reach population? They need to know, because honestly, without the information, these communities actually stands at a very high risk of having this infection, and it can actually kill as many people as possible. So we need to ensure that we find ways in which we can engage public health officials and get information. If yourselves you can disseminate that, but of course, I recommend to the respective organizations handling this to ensure that all these rural health rural communities are actually reached with the key message of COVID-19. No one should be left behind in this fight for COVID-19. Then the second question of cloth masks, washable masks. Right now, the recommendation is only those can be used in the community setup. Okay, and again for the community mask, of course, it depends again with what material was used, the filtration, the breathability of the same cloth mask. So all those things need to be factored in. How comfortable it is for a patient to wear. So those, it's just recommended for the public, the communities to wear that, because it can actually, there's really not much evidence in terms of how effective these are actually within the communities. We hope with this COVID-19 we're going to have now more information in terms of good studies that will look at how effective these masks are within the communities. But of course, if you put on any kind of mask, basically in terms of the one that has the disease, I'm sure in terms of the droplets coming out, that will definitely be lessened. For the one who is, not having any disease, of course, we are hope that, of course, few droplets would actually reach the face or mask. But in the healthcare setup, no rewashable mask supposed to be used. That is highly not recommended in the healthcare setup. So if you are in the communities working with COVID patients in the hospitals, never put on a face mask. A cloth mask, reserve those for the communities. And we don't have much evidence really to really 100% say they're very effective in the communities. The same cloth mask we don't have, so we'll communicate once that evidence comes through. Over.
Fantastic, Doctor. Now we have a question. We have a hand raised from Ms. Ojo. Ms. Ojo, you're unmuted. You can go ahead.
Okay, thank you for this presentation. My question is, while the presentation was going on, I was just thinking about the health systems in low and middle income contexts who are already having fragile health systems. And with this era of COVID-19 pandemic, it's so evident that all resources are being channeled towards, containing the pandemic spread. So what can be done to ensure that other essential services of primary health care are not halted?
Yeah, thank you. Yes, so again, I think that is quite a big challenge, because remember, as public health professionals, we need to ensure that we play an important role in what is, I think, we've all heard of fattening the curve. The important aspect of fattening the curve is to ensure actually the healthcare capacity is not overwhelmed. So we need to ensure that the epidemic is controlled within the limit of the healthcare system, because if you allow the epidemic to overwhelm you, then of course issues of essential non-COVID care would definitely be affected. So you want to ensure that that is prevented. So you need to ensure that the healthcare system is able to ensure that they identify, diagnose, isolate, trace, and quarantine the contacts. Once you do that effectively, your healthcare system will be within the limit to ensure that it remains resilient. And meaning resilient, it means capable so that other services are not affected, because there's seriously a high risk that if we get overwhelmed with cases, our healthcare system can actually collapse. Okay? We're actually going to have a lot of these patients, especially who are vulnerable, coming for reviews, diabetes, hypertension, HIV. These are the people that regularly visit our health facilities. So those would actually be the most hit, because we'll find that most of these health facilities would have been contaminated even with the COVID-19. So the best approach, especially in our resource-limited setting, is to ensure that right now we have the chance to ensure that the curve is flattened as soon as possible, as much as possible, to ensure that the reproductive number is at least kept under 1. And once that is done, then the healthcare system can be resilient, and we can continue to provide standard care for all these COVID patients. So it depends on how readily our countries are actually following the guidelines and doing the needful in terms of controlling the outbreak. That's the only way in which these other essential health services won't suffer. Over.
Fantastic, Doctor. We have a next hand from Bala Jatta. Bala Jatta, you're unmuted. Please go ahead with your question.
Okay, thank you very much for the presentation. My question is, just wanted to know if patients that have recovered, whether there are chances of them getting reinfected again, and if so, what percentage of patients are likely to get reinfected after recovering from COVID-19? Thank you.
Thank you, Jack. Another important question. So basically, there are a few reports that have shown that some patients have gotten the infection, but again, it wasn't really determined if it was really a reinfection or just a contamination, or was it just a detection of just some remnants of RNA which could be not infective. But ideally, in any viral infection, this respiratory infection, what is expected is that once you recover, you develop antibodies. That's hemoglobin M and hemoglobin G, which are supposed to be protective. Important to note that once you develop these antibodies, it doesn't really indicate that you are 100% protected, because you have the hemoglobin M and hemoglobin G. You also need to see if these antibodies that are being produced against the COVID-19, against the SARS virus, are protective, what you know as neutralizing antibodies. So if you have a high titer of neutralizing antibodies that are being produced after the infection, then we can certainly say you are safe, you are protected from the next infection. Again, how long these antibodies last, right now we don't know. The outbreak is still ongoing, but from similar epidemics involving the coronaviruses, in the SARS epidemic, in the MERS epidemic in the Middle East, it showed that both these viruses, these antibodies were only able to last for close about maybe maximum about 2 years. Then after that, no such antibodies were protected. So it could be similar again with COVID-19, but we don't know. Okay, but we don't know if it is going to be a lifetime protection. So right now, studies are being being conducted right now to see how many of these patients that have these antibodies, if actually neutralizing antibodies that are able to protect you from getting a reinfection. But ideally speaking, we should definitely have that protection from these antibodies in any of these viral infection. But I think we can justify this more when we have evidence that these antibodies that are being neutralizing antibodies, they are protective antibodies that can protect you against the COVID-19. Thank you. Over.
Fantastic, Doctor. We have one question from participant. Frequent use of the mask can cause hypoxia. What can we do about this?
Okay, I haven't seen any evidence to say frequent use of mask can cause hypoxia. So if you look at hypoxia, it means your blood's oxygen saturation level is way below 93%. I doubt just wearing a mask can actually reduce that. Using a surgical mask, using an N95 mask, definitely those are designed to ensure that they filter the air that's coming in. Your breathing is going to be well. You don't expect any hypoxia for anyone that's putting on a mask. So there's no evidence to that effect. Thank you. Over.
Fantastic, Doctor. And we have a question from Fodai. Safiatou Fodai, please go ahead with your question.
Thank you very much. And I want to thank this brilliant presenter. And he has so far responded cleverly to all his questions. Thank you very much. Mine is very quick. Your presentation made mention about the COVID-19 be present in Siemens. I want to know how long does it live in a semen, and what will be the discharge message to the male COVID patient on discharge? What will be their message?
Thank you for this question. Yeah, so right now, we don't know at what point a patient will start shedding the virus in the semen. And of course, we don't know right now if actually that virus being shed in semen is actually infectious. We don't have that evidence. How long can virus last in the semen? Again, we don't have that information. As I said, COVID-19, no one is an expert in COVID-19, so we are still learning more and more. And as evidence comes through, I'm sure at another forum, given an opportunity, we should also be able to talk about that. Thank you. And of course, this has implication in terms of our male folk. Of course, they need to tread carefully. Basically, I think the use of protection condoms right now, of course, is highly recommended for all these other STIs. But I'm sure if people are concerned using condoms, if it was possible to have that form of transmission, I'm sure that can prevent it. So those should be the messages that we need to ensure that our people are hearing, because evidence right now is there. It's an isolated semen, but we don't know if it's infectious through that route. Thank you. Over.
Thank you, Dr. Kabwe. So we have last 4 questions, last 4 participants who want to put their questions. Okay, so the next question is from Doris Baronman.
Hello? Hello?
Yes. Yes, Mr. Kadima, you're loud and clear. Please go ahead. You're loud and clear.
Thank you. I was saying that it seems like the progression of the pandemic, COVID-19, is quite slow in Africa as compared to other continents. I would like to know what are some of the factors that contribute to the slow progress of the pandemic that you are observing in Africa as compared to Europe or America, actually. The second question is about the children. It seems like the incidence of COVID-19 is low in children. What could be the reasons? And is there possibility of vertical transmission from a pregnant mother to an unborn baby? The pregnant mother who is infected with COVID-19, can she transmit the infection to the unborn baby?
Okay, thank you. Great questions. So the first one, yes, I agree. in terms of the epidemic, at the number of days that we are in terms of the epidemic, from the first case that was reported in Egypt up to the number of cases that we have, because we have close to about 70 cases right now on the continent. It has been different. Our care wasn't really been that high compared to the way it was in Europe, and according to where it was in the United States of America. So right now, there's really no strong evidence to really say what is working well. Okay, because most government, of course, instituted the recommended measures by the World Health Organization. They did these social, physical, social, measures that were put in place quickly on the continent. So that would have been have done an effect on that. But of course, it would be wrong to state these issues of saying, the black race, our climate doesn't, maybe it's one thing that have made, the COVID-19 to be the way it is on the continent. We don't have that information that, our race is one of the contributors. Because if you look at the United States, a lot of people of color, blacks have actually died. A lot of them have been affected in the United States. So we can be comforted to say maybe it's because of the weather, or maybe it's because of our skin. That's, we don't have the case. We don't know that. Okay. What we hope is that the epidemic remains the way it is. With our fragile healthcare system, I think so far so good for Africa, but we still need to be vigilant to ensure that actually we don't go into a crisis. So far, most countries have actually managed to have cases within the capacity to manage as healthcare systems. The second question. I know, okay, the second question, but the third question was on mother-to-child transmission of the COVID-19. So there is no evidence that a child born from a COVID-19 mother was born positive. Studies that have isolated, I've gotten samples from the umbilical cord, from the amniotic fluid, from secretions of a child born from a COVID-19 patient. No virus was isolated in this, from the placenta, from the amniotic fluid, from the umbilical cord. There was no isolation of the COVID-19, showing that there is right now no evidence of a mother-to-child transmission of COVID-19. But of course, there is a high chance that the child can be infected at birth, immediately they are born. If the mother is positive and no infection prevention measures are correctly put in place, then there's high chance that a baby can get infected immediately they are born, but not intrapartum. That is not, there's no data that there's actually intrapartum spread of COVID-19, but children can be infected if no infection prevention measures are put in place after the child is born. The second question, just remind me again.
Okay, I think the doctor, we lost the speaker, we lost the participant, I believe. Okay. Since we have more questions that has been raised, and I'm seeing that because of the time constraint, I would advise all the participants to please post your questions in the chat box so that we would be able to answer all the questions and we would be able to address all your concerns. Before we close, we have a last participant whose question was from Kennedy.
Sorry, I think. Hi, Mr.
Yes,
Mumba.
Kennedy, you're loud and clear. You're loud and clear. Please go ahead with the question with the speaker.
Yeah, my question is looking at the trend, how the spread of coronavirus, especially in our country, Zambia. I've looked at it started slowly, and it is slowly, and randomly it rises, it goes down, then suddenly it goes down. I would love to ask from the speaker, what are the great measures we have done so far as the nation, so that we can combat it, because people right now, they're living in fear. According to the epidemiological trends, it shows that there's the places where the high risk areas which has been neglected so far, but there's no much attention to it. We have just concentrated where there was only 2 cases. For example, I'll talk about Kafue in Zambia, where they had only faced 1 case, which took it to a lockdown of the city. And then looking at, again, my question was also what my previous person asked. I was about to ask about what effects does it have to the unborn babies, to those mothers who would be found with COVID, which have been already answered, I think so. So far, then the other question is looking at to the analysis of the spread. As we are going to cold season, looking at the countries which was more affected previous was in the line of the cold season, the cold places. The virus had to wipe a lot of people in that areas. But looking at Zambia, our temperatures, you have explained that where there's high temperature, the chances of people to be more affected is less. But looking at this season we are going in, what would be your say? Then lastly, we have been talking about there's no treatment so far. We have no treatment. The only treatment is stay at home. But to the analytical view, we have got two viruses right now which are running, which is a COVID-19 virus, and then we had got what we call hunger virus. We have told, and there are two categories of people. There are rich people who are scared that they will die from virus. The poor, they're also scared, they are dying with hunger. But you tell people to stay at home, there's no people. Why wouldn't you advise those people who have got high economical status to help the poor who are staying at home so that they can have enough food so that we can combat this epidemic or pandemic which has made the world to freeze? So my appeal is, my question is to, how do we go about it for those people who are poor and we tell them to stay at home? We tell them to put on masks. How are we going to help them?
Thank you so much, Mr. Mumba, and I'm happy that some of the questions, sentiment you raised, and you also provided some answers to that, which is fantastic. I'll just probably just by labor to say one or two things. So in terms of how the Zambia has done in terms of our cases, because remember in this outbreak there are phases of an outbreak. The first phase is phase 0, where of course you don't have any cases. The second phase is so it depends which phase you are in. Whether you don't have a case, you have one case with local transmission, you've got a few number of cases with which can be linked to the primary case, or you have cases where you can't even link to any chain of transmission, which is community transmission. So like in the case of Kafue, Lusaka, here in the parts of Lusaka, so there's the clusters of cases, sporadic cases. So in all this, the interventions are different. So they will intervene differently and intervene differently there. Okay, but what is amazing about this is that most of these cases that are found are linked to the original chains of transmission, which is actually fine in terms of controlling of the outbreak. And I think the team so far, from my opinion, I think they've actually done quite a good job in terms of this. Of course, we can't say that we need to improve. We need to improve our testing capacity, but of course we know that is limited. I know a lot of resources are being pumped in, donors here and there, but honestly, to acquire this test is a trick right now. The rich countries have taken advantage of the situation, and they are getting these in numbers, and a lot of these manufacturing countries, they want big orders, which in our setups we are unable to do that. And right now we can only rely on some donations that are happening in terms of the treatment kits. Like right now, we're having this from the Jack Ma Foundation and all that. So in terms of improving testing capacity, yes, that is needed. And right now, the country, I'm told actually they'll start using those machines that we use for testing HIV and also for testing TB, the gene expert machines that are almost in each and every district of the country. So once those are done, I think testing will be rolled out, because we need to test more to really know what's happening. Because definitely we know that a lot of people might have the COVID-19, because most of them actually are asymptomatic. But right now, I would say, of course, they are on course in terms of how they've handled this. So that's my opinion. Because a lot, of course, there's a lot of expectation from the public, but I think that will be discussion for another day. I think I talked about the issues of infection of mother-child transmission. I did mention that one. Then, of course, in terms of hunger versus stay at home, yeah, that is quite a challenge. That's why, some of countries right now, either the States, Zambia as well, Ghana, they've decided to say this is a new normal. How are we going to live with the COVID-19? Because you can't tell someone that hasn't got food to really stay at home, okay? So what we're talking about is how, as the people are going around to get their food, for the economic activities, how are they going to be protected, okay? What things are industries going to put in place to ensure people are protected? What our council is going to put in place to ensure that, markets, where a lot of people congregate and know that are protected, physical distance is going to be there. People are going to wash their hands. People are going to have masks to put on. So those are things that we need to look at, because I agree we can't continue like this. Normal life has to begin as soon as possible, and the opening of economies is gradual, is step by step. You can't do it in one day, but of course things need to balance up in the end. Over.
Thank you, Dr. Patrick. I believe it's a very good presentation. Though the scheduled time was between 12 hours to 1 hour, we exceeded 30 minutes because of the interest from the participants who are having more questions. Thank you so much for your available time, Dr. Patrick. And thank you so much all the participants for your available time on participating in a beautiful session under the topic COVID-19 and other high-threat pathogens in 2020. So we will get back to you soon with the recorded sessions of this particular topic. Also, we will share the presentations which was used by the speaker. And we will see you soon in our upcoming session soon from next 2 weeks from now. Thank you so much, Dr. Patrick. Have a great and safe.
Thank you so much for having me. Thank you. Goodbye.